Hello, dear students. My name is Medvedeva Anna Valentinovna. I'm the assistant of professor in the Department of Pathology of Saratov State Medical University. And today we continue to investigate special pathology. And today I will tell you about diseases of kidneys. Normal anatomy and histology of kidneys. In this slide, you can see normal anatomical structure of kidney. You can see cortex and medullary zone, Meyer calyx, renal pelvis, and all structures of normal kidney. In this scheme, you can see functional structure of kidney. In the cortex zone, we see accumulation of many glomeruli and convoluted tubules. In medulla zone, we see rectus tubules. And in this scheme, you can see glomeruli structure with many arterial small vessels, mesangial cells, basal membrane, and visceral epithelium. What about diseases of kidneys? In the 1827, Bright gives the name Bright disease, which accumulates proteinuria. As a result of proteinuria, we see edema, accumulation of liquid in the organism cavities and tissues, and as a result of edema, high arterial pressure, hypertension. There are three main clinical manifestations of Bright's disease: proteinuria, edema, and hypertension. Hypertension leads to myocardial hypertrophy in the left ventricle. In this photo, you can see serious edema in the lower extremities as a result of disease of the kidney. This old classification of Folgert and Farr in 1914, nephritis, nephrosis, nephrosclerosis, tumor, and congenital abnormalities. But today we use new classification according to functional anatomical characteristics. There are 5 main groups of diseases in the kidneys: glomerular diseases, glomerulopathy, tubular diseases, tubulopathy, interstitial diseases, congenital abnormalities, and tumors. More about each of them. At first, glomerular diseases or glomerulopathy. What's this? This primary and initial lesion of glomeruli. Which diseases in this group? Classification of glomerular diseases. At first, glomerulonephritis, the next amyloid nephrosis, and nephrotic syndrome, which includes lipoid nephrosis, minimal changes of disease, focal segmental glomerular hyalinosis or sclerosis, and membranous glomerulopathy. And more about each of them. At first, glomerular nephritis. What's this definition? It's a double-sided non-purulent inflammation of glomerular system of the infectious, allergic, or instated nature, unknown nature. Which etiological factors of glomerulonephritis? At first, is bacterial components. More often, there are hemolytic streptococcus, but maybe staphylococcus, pneumococcus, viruses. And maybe non-bacterial factors. As example, alcohol, drugs, or cool trauma. Which pathogenesis of glomerulonephritis? There are 2 mechanisms: antibodies mechanism and immune complex mechanism, which may be heterologic and autologic. Antibody more serious mechanism of glomerulonephritis. Circulative immune complexes or antibodies are fixed on basal membrane in the glomeruli. As a result, those immune complexes injure of basal membrane of glomeruli. As a result, we see proliferation of mesangial cells in the glomeruli, and mesangial cells produce interleukins, factors tumor necrosis, and this factor, these biological factors stimulate inflammation. Classification of glomerulitis according to the process localization may be intracapillary in the cells of capillaries, and extracapillary between basal membrane and capillaries and in the basal membrane. Intracapillary glomerulonephritis can be exudative and proliferative. In exudative form, we see infiltration by leukocytes, edema, and hyperemia as a serious inflammation. In proliferative form, we can see proliferation of membranous cells, mesangial cells, membranous proliferative variant, and fibroblastic growth of connective tissue. In the extracapillary glomerulonephritis, can be exudative and proliferative types 2. Exudative, serous, fibrinous, and hemorrhagic, non-purulent, we told about this nature, and proliferative with formation of semilunis, proliferation of cells in the basal membrane. Classification according to the course may be acute up to 12 months, 1.5 to 12 months, subacute 6 months, 1.5 years. Special name for this subacute glomerulonephritis is large motley gay kidney. And chronic, more than 10 years, leads to secondary wrinkled kidney. Clinical manifestation of all glomerulonephritis, we told bright disease, proteinuria, edema, and arterial hypertension. In this photo, you can see different types of glomerulonephritis: intracapillary, serous, intracapillary with proliferation, intracapillary and extracapillary with production. In this photo, you can see large motley kidneys, subacute form. In this photo, you can see histological examination of subacute form, this very, very aggressive type of glomerulonephritis. We see proliferation of cells in the basal membrane of capsule in the glomeruli and pressure for capillaries. We see affected of many glomeruli. This situation leads to acute renal failure. In this photo, you can see accumulation of immunocomplexes, cellular semilunis, fibrin expression, this with immunocomplexes accumulation. In this photo, you can see fibrin accumulation in the capsule of glomerulus. This special staining for fibrin, blue color. This intracapillary glomerulonephritis, proliferation of cells in the between capillaries. Which complications of glomerulonephritis? I told that subacute form and acute form can lead to acute renal failure. Acute glomerulonephritis is more favorable type. Subacute very, very unfavorable. Chronic form leads to replacement glomeruli to connective tissue, fibrosis, sclerosis, and leads to chronic renal failure with uremia, cardiovascular failure, and cerebral hemorrhage. What about amyloid nephrosis? More often, it's secondary amyloidosis. We talked about amyloidosis in the many organs and in the kidneys too in the last semester. More often we see secondary. What it means? That means means amyloid nephrosis is a complication of many diseases with destruction of our tissues and organs, For example, due to tuberculosis with destruction, due to syphilis with destruction, rheumatic diseases, chronic inflammation, chronic abscesses, or as example, chronic osteomyelitis, all those diseases can lead to amyloid nephrosis, accumulation of abnormal protein in the glomeruli. Which stages of renal amyloidosis? First stage, latent amyloidosis and sclerosis in the stroma of pyramids without serious clinical and anatomical manifestation. The next, proteinuremic. We see accumulation of amyloid in the glomeruli, in the stroma, and the wall of large vessels. The next, nephrotic stage, amyloid accumulates in the glomeruli, in the stroma, in the wall of large vessels with secondary dystrophy of tubules. We see in the kidneys large sebaceous kidneys or big sebaceous kidneys. Those kidneys are increase in size, very, very solid, consistent in the and pale on incision. And the last stage is azotemic amyloid wrinkled kidney. This last stage, this stage leads to chronic renal failure. Which outcomes of amyloidosis in the kidney? Maybe acute renal failure, but more often in the last stage we see chronic renal failure, nephrogenic hypertension, and autoinfection. In this photo, you can see anatomical examination of large sebaceous kidneys due to amyloidosis. Pale color on the incision, without normal anatomical structure, without cortex and medulla zone, pyramids, large and very solid. In this photo, you can see histological examination of amyloidosis in the kidneys, hematoxyliniazine staining. We see accumulation of amyloid, look, as a pink masses, homogeneous pink masses in the large vessels in the glomeruli, and replacement glomeruli to amyloid. In this photo, you can see accumulation of amyloid as a pink masses, homogeneous and pink masses in the glomeruli, large vessels, and the stroma. But we must use special staining for amyloid, Congo red staining. Red masses, due to this staining, is a result of accumulation of amyloid. Congo red staining too in the glomerulus. The next disease, the next syndrome, nephrotic syndrome. This syndrome includes 3 diseases. Are lipoid nephrosis or minimal change disease, focal segmental glomerular hyalinosis or sclerosis, and membranous glomerulopathy. What about lipoid nephrosis or minimal change disease? Disease of small sprouts of podocytes. Anatomical picture, this congenital disease. Anatomical picture, large white or yellow kidney is a result of accumulation of fats in the tubules. Histologically, we can't see changes in the glomerulus, but we see complication of defects of small sprouts in the podocytes, fatty dystrophy in the epithelium of the tubules, and outcome chronic renal failure. Look, in this scheme, you can see defects in the absence of the small sprout in the podocytes. As a result, we see defects in the basal membrane and infiltrate light proteins and fats to epithelium. Look, in this photo you can see defects and accumulation of fats in the epithelium of convoluted tubules. As a result, we see white or yellow color on incision of anatomical structure. The next disease of a nephrotic syndrome is focal segmental glomerular hyalinosis or sclerosis. Focal and segmental. We see segmental affection, some glomeruli only, partial affected, and partially defect in the glomerulus, in affected glomerulus. We see hyalinosis and sclerosis. Pathogenesis unknown and poor prognosis in this. Look, for differentiation, focal affected, we see affected of some glomerulus. Due to diffuse disease, we see affected of all glomeruli. Segmental. What means segmental? If we see segmental affected, in the affected glomerulus, we see changes in the part of glomerulus. In the global disease, we see effect to all glomerulus. And the last, focal segmental glomerular sclerosis, we see sclerosis and hyalinosis in the part of glomerulus. And the last disease of nephrotic syndrome is membranous glomerulopathy. This disease looks like as a membranous glomerular nephritis, as the inflammation, but without inflammation. We see autoimmune reaction against unknown renal antigen, immune complexes appearance, thickened basal membrane in the glomeruli, and I told you that this disease looks like the membranous glomerulonephritis. Look, membranous glomerulonephritis with a proliferation of membrane cells, and histologically we see similar picture due to membranous glomerulonephritis and membranous glomerulopathy. The next group of diseases in the kidney is tubulopathy or tubular diseases. It's initial or leading lesion of tubules epithelium, convoluted tubules epithelium. There are two courses, acute and chronic. Due to acute course, we see acute renal failure or necrotic nephrosis. Morphological examination is necrotic nephrosis. Clinically, we tell about acute renal failure. Due to chronic course, we see diseases, myeloma. Due to myeloma diseases, is gouty kidney. More about acute renal failure or necrotic nephrosis. It's syndrome which morphologically looks like acute tubular necrosis. Which pathogenesis of acute renal failure may be direct mechanism and indirect. Direct, nephrotoxical substances, these poisons or toxins influence to epithelium, and indirect due to shock situation, due to disturbance of blood circulation, due to ischemia of cortex zone and deficiency of arterial blood circulation. Look, anatomical picture. Due to acute tubular necrosis, we tell about shock kidney because more often we see those kidneys due to shock situation, all types of shock. Hemorrhagic, hemolytic shock, toxic shock. Due to this situation, we see flabby and thin cortex zone with necrosis of convoluted tubules and large dark red medulla zone, pyramids. Which stages of development of acute renal failure? First stage, shock stage. We see action of etiological factors, toxins or shock situation. What can we see? Collapse of capillaries, of glomeruli, dystrophy of tubules, epithelium. Due to oligoanuric stage, clinically we see oligo or anuria as a result of necrosis and edema of tubules epithelium and infiltration of the stroma. And the last stage, recover or regenerative stage. If we see unfavorable outcome, we see death in the second stage, oligo and uric stage. If we see favorable outcome, we see the last stage, recover stage, hyperemia of glomeruli, regeneration of tubules epithelium, and focal nephrosclerosis. Look, this histological examination of necrotic nephrosis or acute renal failure. We see ischemia of glomeruli and edema and necrosis in the epithelium of convoluted tubules. Pink color without nuclei. This destruction of tubules epithelium, lysis of tubules epithelium, and maybe proliferation of new cells, recover state. Which outcome of acute renal failure? Favorable, recovery, and unfavorable, acute renal failure, uremia. Due to chronic course, we see affected of convoluted tubules. Due to myeloma disease, we see accumulation of abnormal protein, myeloma protein, into the tubules, and chronic renal failure. Look, this abnormal protein into the tubules. Due to gouty, we see accumulation of salts, of urinary salts into the epithelium, and chronic renal failure too. The next group of diseases in the kidneys is renal cell carcinoma. What's this very, very often carcinoma, cancer, derived from tubular epithelium, nature from epithelium of convoluted tubules. Which risk factors? Smoking, hypertension, cadmium poisons. Clinically, what can we see? Hematuria, abdominal mass appearance, and flank pain. If we see metastasis, only 5-year survival, about 5% only. Look, in this photo you can see carcinoma in the kidneys, large node, anatomical picture, many cysts, white masses, white yellow masses. This node is or motley masses. If we see affected of pelvis, appearance of carcinoma in the pelvis at first, before carcinoma, we can see appearance of papilloma, benign tumor, which lead to papillary carcinoma, maybe non-invasive, invasive form, flat non-invasive, and flat invasive carcinoma. This transitive type of carcinoma. Look, in the urinary bladder, in the pelvis of kidney, we see bladder carcinoma from not flat, transitional urinary carcinoma. What about pyelonephritis? Pyelonephritis is interstitial disease. We see inflammation between glomeruli and tubules as a result of invasive kidney infection. Which nature? Escherichia coli, Proteus. Clinically, we see fever and flank pain. In this photo, you can see mechanism of development of pyelonephritis. The affected of interstitial inflammation. This ascending infection more often. Escherichia coli, Proteus, Enterobacter, affected of urinary bladder, and at first affected pyelopelvic inflammation, and spreading of infection to kidney, to parenchyma of kidney, and appearance of zone of inflammation, purulent inflammation. Look, in this photo you can see acute pyelonephritis with formation of many abscesses, apostomatous abscesses. This is very aggressive and very serious inflammation. Look, apostomatous pyelonephritis. We see affected of pelvis in the kidney, and histologically purulent inflammation, inflammation in the interstitia between glomerulonephri and tubules. Purulent inflammation, more often we see formation of abscesses and maybe spreading of this inflammation from the blood and formation of sepsis. Look, chronic pyelonephritis leads to scar formation in many zones of kidney and chronic renal failure as a result, as the outcome of this disease. Sclerosis and chronic renal failure. That's all about diseases of kidneys. More information we will discuss in the practical lessons. Thank you for your attention.